And now I'm delighted to introduce our first keynote, and we're to be joined by Dr. Tessa Fulton from National Voices and Helen James, who some of you will have heard from this morning, and is the founder of Nutriri as well as the CEO as well. So can I just ask everybody to give them a warm welcome to the stage?
Hello, tough act to follow.
Definitely.
Helen did suggest we do some interpretive dance, but I don't think we'll have the same charm. So, so we are here from the voluntary sector, which is obviously a really key player in our systems. Can people raise a hand if you're also here from the voluntary sector? Because I haven't heard much yet. Great, I'm really glad you're here. So Helen will introduce herself in a moment, but just to start with, I wanted to tell you a bit about who we are at National Voices. We are a national coalition of health and care charities. We're the largest one in England, and we've got over 200 VCSE organisations that make up our membership of varying sizes. So some are really small grassroots charities, and some are big, your big recognisable national charities like Alzheimer's Society, Diabetes UK, etc. And basically our role is to co-produce with national policy makers, with people with lived experience, whether that's coming through the voluntary sector or working directly with people who are accessing or needing health and care services and health and care systems, to find solutions that we can implement to particularly reduce health inequalities and to make all of our health and care services more inclusive. And so we cover cross conditions, cross communities, and one of our members is Nutriri, which the bulk of our talk today will be around the work that they do. I just wanted to bring the kind of, I guess, the flavour of lived experience and what it can bring to these types of conversations. At National Voices, we've developed a series of I statements. You might have seen similar elsewhere in the care system. These were developed by people with lived experience of a range of often long-term health conditions to really articulate what they want and need from healthcare. And our goal is to use them to make sure that what matters to people who are working or running or leading health and care service is the same thing that matters to people who are using the services. And these I statements are an articulation of that, that's in plain English, that can be used by someone with lived experience or a carer to think about the care they're getting and to advocate for themselves. But it can also be used by people designing and delivering services to look at, are you doing the things that matter to people? So I won't read them all now, partly because I can't read the screen. For example, I make decisions that are respected. There's one that I really like. So some of these got updated during COVID. We did lots of online work called Our COVID Voices, where people who had long-term health conditions were slipping through the cracks of what was being offered at the time, and their health was often deteriorating. And that's where the final one I like is I'm not forgotten. And I think people living at higher weights often fall into that category, like we heard this morning of the example of that you wouldn't really get in any other circumstance of just go away and do something yourself and then come back, which you wouldn't be told for a mental health problem or a broken injury, even if those things might have arguably similar levels of personal responsibility. We don't seem to apply it in the same way that we do. There's, as we said this morning, the last acceptable stigma. And then to move it back into the weight space, this was National Voices got commissioned by NHS England towards the end of last year, once the NICE guidelines were approved for the so-called weight loss drugs. We were asked to meet with people particularly at risk of health inequalities to find out what they needed and wanted to know about weight loss drugs to be able to make an informed decision about whether it was right for them. What the interviews revealed was that it was a much wider conversation, as a lot of you will expect. And I was really struck working with this group of people of how expert they are in weight loss, because often they've been from, I say they, we have been in this society, this journey, since puberty. Often a lot of women particularly said around puberty, that's when they started learning about dieting and those kind of things. So they don't need to be told how to eat less and how to move more. They've known that. Some people for 60 years they've been hearing that. What they do want is services where they can access the healthcare that they need for the condition that they're actually presenting with. So we heard about pregnant women who had really high levels of serious morning sickness, not being treated for it because they weren't at risk of reaching a dangerously low rate, although it obviously was still completely debilitating and potentially a risk to the fetus. And people being sent to exercise programs that aren't appropriate because they don't have the mobility issues, all of those kind of system-wide issues. So I think what I wanted to bring really is where lived experience can guide us in this. And I'm going to kind of interview Helen to pull out a bit more what that's all about. So I think this is really nice coming after the children, actually, that people really wanted hope. And in a lot of people's living memory, the example of hope they have was the Start for Life programme as it was in, was it the early 2000s? I forget the exact year it came in, when a sort of universal service where you could go to a family centre. It wasn't stigmatising. People from all classes in your neighbourhood were there. You could get a breastfeeding support. You could just have a chat. And if you needed a more serious medical referral, it would be a way in. And people are talking about we need that kind of hope again that is for the whole community and is bringing together all the parts of the system, really. So if anyone wants to find out more about National Voices, there's some contact details on there. We really welcome new members as well. A lot of our members don't pay any fees because they're really small in size. We just think we're all better together to influence particularly national health and care policy with the new government. So do join us if that's of interest to you. Coming to our member Nutriri, we just wanted to start with a Slido question to see where people's thinking is at before we tell you what we think. We want to hear what you think. So, do you want to ask the question?
Yeah, it's up there really, isn't it? So what are you already doing to create health that doesn't centre on weight? And I'd argue that you're doing really, all the work is about centering health and improving health outcomes for people. So, yeah, but I thought we'd give you the opportunity to focus on the positive things that you're already doing that don't centre on weight. It'd be really good to hear about some of those. Yeah, if you
I can do it while because we're going to show you a video to introduce Nutriri. Sorry.
No, it's fine. I think the Slido's on the desk, so
okay.
Yeah, that can be done as we go through.
Since 2015, we've been hearing from people about their experiences of weight talk and how this affects them. We've also been listening to those who work in health management and promotion to discover how their work feels. We've examined 3 decades of policy and strategy designed to improve population health. And we've looked into spending focused on weight change and its impact on health outcomes. In May 2022, we took some of this data to the House of Commons, where Jeremy Hunt asked us about weight discrimination in healthcare. Everything we do is informed by the lived and living experiences of people, especially the 300 or so that took the time to comment here. Pursuing and monitoring weight change is not having the positive effect on population health that we previously thought it did. So a group of volunteers got together and talked about what needed to change. We discussed the research and evidence that already exists to inform the design of our first Food and Body Ease courses. And some of us went on to test and learn with the course, facilitating one-to-one coaching or in small groups. We used Happiness Pulse to measure our impact, a measure of social and emotional health, and we partnered with accessible Pilates group Mobilates to measure increases in activity over 6 weeks. Robust research over 14 years with over 11,000 participants shows us that it is the beneficial behaviours that we sustain over time that bring health, and not changing BMI. The impact of Weight Talk in the consultation room and beyond states that weight stigma among healthcare providers is linked to healthcare avoidance in patients, including underutilisation of preventative healthcare and screening. Evidence consistently demonstrates that stigma is more likely to lead to increased allostatic load, higher prevalence of chronic diseases, and further weight gain, independent of BMI. Meanwhile, healthcare systems are still focused on weight change for health improvement, and referrals are being made to weekly in-person and digital slimming clubs. Questioning individual willpower, success or failure, rather than questioning the out-of-reach and unsustainable weight classifications. So we drew on the lived experiences of the evidence base again to co-create the weight neutral training course for social prescribers with formats for time-poor clinicians and the wider food and movement professional workforce, testing and learning as we go. In time, we hope to move a largely weight normative system approach towards a weight neutral inclusive route to improved population health and poor health prevention. The co-production continues with every cohort of weight neutral training and food and body ease participants that come through our door.
So I think before we go into sort of the interview, the Q&A bit, and I'll be prompting myself with text here because I need it. It's really good. She spoke quite well, didn't she, on the video? Is to say a really big thanks, one, to National Voices for bringing us along. We feel so passionately about this. We've come up from Devon. And really want to congratulate Boost and NENC for being ahead in the race to do different. I really feel it's that way. You know, we speak to other ICBs and ICSs, and you're doing great work here. Yeah, and I think hopefully my answers to your questions will bring through how we champion what's already happening rather than finger pointing and criticising. So, cool.
So do you want to start by telling us who you are, but also what the title of today means to you? What does the weight is over mean to you?
Yeah, when I saw it, it immediately spoke to the focus on weight can be over and that everybody will benefit from us working towards that, to put it really simply. And because we realised that measuring real health markers is more likely to rebuild the trust and engagement in the patient group that are currently delaying or withholding altogether. And that might be from internal self-stigma or external actual historical stigma, or most often both. So not every higher weight person would know that they benefit from a weight neutral system, but having stigma-informed systems and bias awareness and known what the impact of stigma actually is, we would all benefit from that. So, yeah, VCSE Nutriri set it up about 9 years ago to not only talk to people that went to slimming clubs, because that's what I did for decades, and changed my weight drastically lots of times. We spoke to the workforce and said, how does it feel to deliver on weight management policy and healthy weight policy? You know, does it feel a bit ick? Does it not? You know, what works, what doesn't? And what works aimed at preventing poorer health rather than preventing obesity. I'll do that for obesity.
So you've partly answered this, but why do you think we need to shift to a weight neutral way of working now?
Yeah, so it's well researched now that talking about weight leads to fewer cancer screenings, it erodes trust, and is setting up the individual to fail. Okay, we've talked a lot about that throughout the day already. And actual behaviour change is less sustainable when tied mainly to weight change. So when we look across the core 20+5 groups as well, of the population, it's weight focus that is leading to less engagement around long-term conditions. So we can't separate people's weight out from everything else that's going on with them. So that lack of engagement is across the board, protected characteristics or not, and health conditions prevalent. So why wouldn't we want to change this? We're all here for better health outcomes. That's what we're here for. So why wouldn't we want to have less of a focus on weight once we learn that it will actually start to rebuild trust and engagement rates?
And just listening to you talk, it reminded me of similar shifts in mental health and wider services around trauma, moving to a trauma-informed system. And I think whenever we talk about this kind of system transformation, there might be a worry. How are we going to make such a transformation when we're already in a pressured system? Is it possible in the current resource environment to do this kind of work?
God, I've got lots to say. That's a big question. But it's simpler than we think. So if it's about changing just, say, the KPIs, so it's about letting us get on with our great work without holding weight change as an outcome, that will increase engagement. It's an easily measurable, an easy measure of health equity that we're creating in the system together. You know, when you've got more people getting involved, staying engaged, doing the behaviour changes, but we're taking the pressure away from as weight change, their health will improve. I mean, the allostatic load, the stress, the effects of stress, you know, whatever the stigma is, whether it's weight stigma or not, whatever the stressor is, you know, that's really what's at play here. And talking about weight is stigmatising, even if it's me talking about myself in my group of friends. You know, I don't know how we can destigmatise a weight conversation. And the easiest fix, you know, to sort of give practical advice, if you like, is if someone's coming in asking for weight management support, there is a prime opportunity of having engaged patients sat right in front of you, and you can say, right, well, we've learned to actually focus on X, Y, and Z, and for them it might be their nutrition, it might be their activity levels, it might be their isolation, it might be, you know, lots of different reasons. We fix poverty, we fix health. We fix access, we fix health, you know. Fixing obesity isn't really fixing much. So I think we need to give ourselves more credit of the work that we're actually doing.
And in terms of what we should measure instead, is it those sorts of things, the sort of patient outcomes, other patient outcomes, whether it's increased movement? What's your thinking around KPIs?
Yeah, so whatever's relevant for the individual presenting, you know, there might be a cardiovascular patient, there might be diabetic, you know, measure the things that actually measure their health. So, you know, whatever the specialism, I'm not a clinician, you know, whatever clinician you are, measure that.
Yeah,
you know, yeah.
It says on the T-shirt if you forget later. And finally, what led you to creating Nutriri, aside from what you've already told us?
Naivety that I could do something. I didn't really know what weight stigma was when I got going either. It was very much about creating a service that we could do weight loss better, because I happened to be losing weight at the time. I learnt mindful eating as well. It was like, oh, okay, this is it, this is the fix, you know, because I was still on that weight-focused train of thought. And so, yeah, naivety got me to start a group, and then I realised quickly, actually, we need to be having a different conversation. So what keeps me going is that it's the right thing to do, but actually what really keeps me going is finding ways that we can co-create, you know, and do it together, because what's the point in, you know, trying to be right about something, you know, if you're not hearing what others are saying about it as well. So it's not about what I know, it's about what you know, and, you know, how do we create those stigma-informed systems of care together? How do we create weight-neutral triage? But yeah, living experience, because it's not past, it's, you know, it's there every day. So, yeah.
Thank you.
No problem.
Thank you so much. And I think it's only right we start the activity part of the day with that reminder that we should be putting living experience at the centre of everything we do. When we saw the stats earlier, we know just how many of us in this room proportionately are facing these issues.